Welcome back to the Anja Health podcast. Today, I'm super excited to have one of our medical advisors, Dr. David Kim, with us. You have a long list of accolades, so I'm super excited to have you with us. Dr. Kim has been an OBGYN for 27 years. However, you're not only an MD, but also a PhD and an MBA, and you've been ACOG's Excellence in Medical Student Education. You've gotten that award. You've also been a top doctor by LA Magazine and the CREOG National Faculty Award. You've also had the California Medical Association Foundation Robert D. Sparks and MD Leadership Achievement Award. So I'm super proud to have you as one of our medical advisors, and I'm really grateful for you taking the time today to be with us.
Well, thank you so much for inviting me, Catherine. I'm really excited to be here.
Awesome. Cool. So I know I gave a bit of background on your experience, but I'd love to hear it from your point of view, especially the journey throughout your various degrees and how they've kind of interwoven together and what led you to the decision to practice medicine as the primary part of your profession.
Yeah, I mean, the only thing I've ever wanted to do was become a physician since I think the time I was 11, because I just wanted to, I always liked science, and I just wanted somewhere I just decided if I have to invest all this time into something, because you have to put a lot of time into anything you do, I just wanted to be something that would transcend like culture, time, religion, anything. And medicine was like just one of those fields, like you could actually help people, and no matter where you were in the world, no one could kind of take away that knowledge and skill set away from you. So that's just what I had thought early on. So I was always wanting to do that. I always had this sort of secret desire to be like an inventor or to do something like discover something great. And I think that's where just the idea of trying to do research, which led me to my clinical research and area of doing my PhD in. That's what I was following. Because especially at that time when I was finishing residency, there wasn't a lot of research coming out in OBGYN. There were in very certain subspecialties, but not necessarily just general OBGYN. And then the MBA, I think, came out of the fact that somewhere early on, I just kind of realized you can't really accomplish anything at a big scale without understanding how the universal language of finance works and sort of just the business operations of any large endeavor, even if you're a nonprofit. Most hospitals are nonprofits, but still they have to deliver value and a service in a way that generates an income to invest into more services. So I was just sort of always interested in that. And I think at some point during my residency, I met a chairman of one university. He had done all that. He had the MBA, had done all research. And I remember him just saying, just do all those things, but do it after you become board certified, because just people won't respect you. And so after I did my training and I got my board certification, which is like 2 years after you finish residency, after you've taken the written boards and passed it, you have to collect cases for 2 years, and then you take oral boards. Everyone in the country flies to Dallas to take their oral boards. And then when you get board certified, once I hit that point, I was like, okay, now I'm gonna like, I was already pursuing my graduate degrees and master's and PhD in clinical research, but then I decided at that time, okay, now's a good time for me to do my MBA, which I just happened to really enjoy, so I really liked it. But in the end, still, I'm a physician. I want to help people, and we're just, the way I would just think about us, everyone in healthcare, we're just always trying to put our energy and effort to improve things and leave people better than where they were before, the most sort of optimal self. So that's just, that's the most enjoyable part.
Yeah, that's awesome. My dad, he got an undergrad business degree and then 3 years in pivoted to medicine. So sort of similar. But yeah, that's awesome. Cool. Well, I'd love to pivot into cord blood banking, especially because you are one of our medical advisors. So in your eyes as an OBGYN, what are the pros and cons of cord blood banking, and how do you typically present it to parents if they ask about it?
Well, I'd say the pros are that, of course, that you're collecting, the hemopoietic stem cells, and that you could save that, whether it's for donation or autologous, you're saving it for your own child. If you're doing it for donation, you're contributing to a bank, a public bank, just the way like a blood bank. And so that can possibly be used for other people who might need access to it. For For your own private banking, it's just sort of, the pros would be you have an insurance of stem cells that are something that can be used if for some reason your child or had some sort of condition that could benefit from transfusion with stem cells. And then I think the other thing that's, I guess, insurance in a sense benefit is sort of banking on the hopes of solving some of the more adult diseases that occur later on that stem cells can be applied for, which there's just a lot of research going on in that area. I think the only con would be, the downside would be it's just a cost issue, which of course that's what you're addressing. But I would say the only thing that is a con for it. Yeah.
Yeah. Okay. Awesome. So I know you have 2 kids. So when you had kids as an OBGYN, how did you structure your birth plan, and did you look at cord blood banking for your own kids?
I do, and I have I bank their blood and their umbilical cord tissue. Let's see. In terms of birth plan, I don't know if there was a tremendous birth plan, which is funny because I'm an OBGYN, but I think I've done this so much, and this is all I do. I think it's just something that my wife and I already knew what we were going to do, and for us, because I think I've just seen so many things, great things, and also unforeseen, unfortunate things. The only thing that we had cared about was safety of her and safety of the baby. So whatever needs to be done. And so we try not to be too, I guess, attached to some plan.
Right.
Just same thing when we got married. It was like, both of us were like, if things don't go exactly the way they're supposed to go, that's why I tell my patients, you have this idea of how, it's like a wedding, you have this idea of how it's supposed to go and all the details and all this stuff, but when you get too attached to it, it sometimes interferes with the experience of just being a joyful occasion, and the thing that really matters, which is actually getting married, signing the documents, doing the commitment in front of friends and family. And so that's what I usually tell my patients about labor too. It's like, don't lose focus of just trying to enjoy the experience and, have a safe outcome, safe baby, safe mom.
Right. I'm curious, because you and your wife are both Korean, if there are any Korean postpartum practices that you tried to incorporate in your birth plan or the postpartum experience. Because I know Korea especially is kind of famous for having like a really intense postpartum experience that benefits the mom.
Yeah, they do, and I learned more of it from my wife. And in Korea, there's you actually check into these sort of hotels where they're just serving you. They're taking care of mom, taking care of the baby for a full month. So the dad's not even staying over. He visits. And it's just the idea that mom needs that full month to recover. I think in the U.S. I think LA has one place, but it's not, even amongst Koreans here, it's not as popular. And I think in Korea it might be more popular because it's so dense. There's 15 million people in Seoul, and the houses or the apartments are smaller, so it's just easier to go somewhere where they're just going to take care of you. And then they're nurses, so they're taking care of you. They know what to do with the baby and mom. Here, I think they're just, I don't think I'm even saying it right in Korean, but a sanho ajima, and what they do is they come in and they'll stay with you for a month. And they're cooking, cleaning, all that, but they're doing more than that. They're actually helping take care of the baby, help take care of mom, cook for her in ways foods that are the best for healing and recovery, teaching her how to breastfeed, dealing with sleeping issues of the baby. So there's not quite an equivalent. There's sort of the idea of a night nurse, kind of thing in the U.S., but it's not quite the same, because this person comes in, literally just takes over and teaches you how to do everything, and sets up your life like that. So
right.
So it's great. That's what we had, and so that was really wonderful.
Oh, cool. So you did have one.
We did have one. Harder to find during the pandemic for sure. And then also lots of myeokguk, which is seaweed soup. So that's I think that's a unique thing that Korean women, after they deliver, eat a lot. As a matter of fact, I heard some studies that the Korean women who come here to deliver, that's their biggest beef, is that they're not given seaweed soup after delivery in the hospital. So, because of course, the one really makes that. Yeah.
Yeah. I spoke with an L&D nurse from Cedars. She was on our podcast last week, and she talked about how she typically will make like a really, really sugary drink after birth, and it's like a mixture of a bunch of different sodas. Not quite seaweed soup.
Well, so I didn't know where. So yeah, I wouldn't be all into that sugar, but I didn't quite know where the whole seaweed soup thing came into. Like, well, what does that have to do? So that's why Koreans too, on your birthday, you're supposed to eat seaweed soup because you were born. That way, your mother drank it or ate it, and so I didn't quite know where that came from. So I looked it up. Apparently, somewhere hundreds and hundreds of years ago, Koreans observed that whales, after they gave birth, would spend a lot of time eating seaweed.
Oh, okay.
And so there was this thought that the whales have, like, they're onto something. Like, and I guess there's a lot of iron, in seaweed. So
it's alkalizing.
That's where it came from, I think. Yeah.
Okay, awesome.
Yeah.
Well, as an OBGYN, why did you decide to bank cord blood and cord tissue stem cells for your kids?
Well, I guess I don't know if I have like a great logical reason. I just wanted to do it, and I was lucky. It was free. So
as an OBGYN,
as an OBGYN, yeah, it was free, and so I thought it was just something like insurance, So it's someone gave me free life insurance, I probably would just take it.
Yeah.
So I thought it was good to since I talked to people about it and counsel people, I just thought, you know what, I should have it and see what's involved in it and see what paperwork and what process you go through and everything. So
that's awesome.
Yeah.
So when pregnant parents ask you if they should consider banking their own stem cells from their umbilical cord and placenta, how do you usually advise patients?
Yeah, I think I've changed over time just the way I approach counseling patients about anything anymore. I used to be like, hey, this is what you should just do, but I really try to assess where they're coming from first, which I don't always get right. But, sometimes cost is a really sensitive issue to a lot of patients. And I just sort of, through my relationship with them, I try to get a sense of that. And I don't, when a physician says something, especially when you're dealing with something very important and intimate like reproduction and pregnancy, and I also don't want to make them feel like somehow they're failing if they decide not to get it. So I just usually talk to them about it's an insurance, and now it's a little bit different if they already have a child with some sort of genetic disorder, some sort of illness, something that could benefit from some. Of course, I'd just say you should do it. You want to collect it. But if it's their first child and, we don't know, they don't have any history of genetic disease or it's not something they've even thought of, then I just usually would just bring up it's an insurance. And if it's something that you can afford and it's something that you think would be helpful for you, it's good. You have one opportunity to get it. That's just the thing. But I'm the same way about breastfeeding. While I encourage, let's say breastfeeding, I don't want to make them feel bad. There are just some women who can't breastfeed for all sorts of reasons.
Right.
And it's just awful for them to feel guilty about it later and affect their mental health. And so I just try to do the same with almost everything I counsel.
Okay, awesome.
Yeah.
Well, my last question around cord blood banking is, do you typically do delayed cord clamping? And if you do for parents, then how do you also make sure that they have enough cord blood to be stored?
Yeah, so we do, all of us in our group do delayed cord clamping for about a minute. But if someone is banking their own blood, what I usually say is, so the whole delayed cord clamping, it's a popular notion, but really the studies and benefit from that was in preterm babies, so that they were transfused less, they had less anemia. There's not as much benefit, very smidgen, barely any benefit in a term baby. So in a term baby, if they're wanting to get cord blood banking, I just usually will tell them, this is what I would do and recommend. I might only delay cord clamp for 30 seconds or less because, if you're paying all this money, the whole idea is for us to collect enough stem cells for it to be useful. And they usually understand that, and they're totally fine with that. And so then I just try to collect as much blood as possible for stem cells. Yeah.
Okay, awesome. Do you have any questions for me about Anja Health?
About Anja Health in general? Well, I'm very fascinated, interested in how you've, created and done all this. From the first time we met, I was talking to you about it. You know what? It's interesting. If you were, I don't know, it's like totally random, but if you were to start another healthcare service business or something, would you do anything differently, or would you do something sooner, quicker, or?
Yeah. I think, I don't know, it's been kind of interesting creating all this content around not just cord blood banking, but pregnancy in general. I think I probably would stick to women's health. I think, have you seen the company Oath Care? They're basically trying to compile automatic telehealth access to like a lactation consultant, a therapist, an OB, a midwife, and a doula all in one place. And I think that's an interesting concept. I also think the Korean model of care is interesting. There's a company called Chio that's been up and coming, and they're trying to open similar clinics in Brooklyn. And then there's also a company, ULA, that combines sort of doula and midwifery with OBGYN advisement care. So yeah, I think it's interesting overall. Like even today, I read a New York Times opinion piece that was that the headline was America already knows how to fix. Or America already knows how to make births better. And it basically talked about how California has actually done like a relatively okay job of improving maternal mortality.
They've made a strong effort.
And a lot of it is related to like better representation within Black communities of Black providers and increased midwifery access and things like that. So I feel like overall, diminishing maternal mortality is something that I would be passionate about. Even in college, like I took classes related to it. So I feel like it makes sense that I ended up in something pregnancy adjacent.
Great. Wonderful.
Cool. Well, I know you wanted to chat about labor inductions. I'm curious what in particular attracted you to this topic.
I think it's, I think I was thinking about this topic because it's something we do very commonly, but yet it's a little unexpected. So usually when a woman's pregnant and she's, going through the prenatal care process, she's not usually thinking, I want to get induced. That's not usually the forefront of their mind. So when it does come up, it is just so jarring, maybe too strong of a word, but it doesn't align with what they were imagining. And there's so much, I think, a visualization and I think social media, friends, and all that. Just there's a sense of like, this is how I want the labor process to be, but there's a lot of times that we need to do an induction or recommend an induction, and I think it's just initially kind of jolting to patients. To us, it's very routine. Probably 20 to 30% of the patients in the country, women, will get induced.
Oh wow.
And to us, it's a routine process, but I think to the woman, it's not. And it's hard to sometimes all of a sudden when you say, oh, this is the best thing to do, to be able to shift that perception or frame of mind on a short visit. Yeah.
Do you ever get patients that want an induction unnecessarily? Like, for instance, if they want them to fall under like an astrology sign or
definitely
have a birthday?
Yeah, I mean, that doesn't happen quite as much. I've been at some places where their spouses are military, they're going to be shipped out, and they need to be induced earlier. Occasionally, I'll run into superstitious stuff with numerology or this and that. Sometimes it has to do with logistics, like their mother might be flying from another country and they have to. But I would say that majority are not like have this burning desire to be induced. Yeah.
Right.
Yeah.
So when and where is a labor induction necessary during pregnancy?
That's a whole like chapter textbook, but I'll break it up generically into a few areas. One is maternal reasons. They're for the mom, we need to do it. Fetal reasons, because of the baby, because we're worried about the baby. And then the other reason might just be sort of social or logistic reasons. So I think when there's a clear medical reason, that's usually very clear. There are certain medical reasons that we definitely have to do an induction. I think some common examples would be like preeclampsia, where the mother's blood pressure can go up high in pregnancy, and the mom can, in rare cases, have seizures and stroke, but also affects the baby and baby's growth and oxygen perfusion through the placenta at some point. So those are common ones. And I say the common one that I think patients have some resistance to, which I understand why, is that the baby's just measuring kind of big. And so our practice is that we usually do an ultrasound at 36 weeks. That's the last time you can kind of do it where the ultrasound's not wildly off on the measurement, because it gets worse and worse in accuracy the further you go along. And if the baby's measuring large, like 90th percentile, we'd recommend induction generally at 39 weeks, because there's these really rare cases of what's called shoulder dystocia, where the baby gets stuck, and also just increases the risk of C-section if you keep going. So I think some people understandably want to go naturally, but any OBGYN, which is most people who've been practicing for a while, if you've been practicing only a few years, you may not have experienced it too much, but all of us have experienced where the baby gets stuck, and it's very unpredictable. It can even be in a smaller babies, but certainly if it's a bigger baby, there's a little bit more chance of that happening. And there's only so many maneuvers that we can do to get the baby out once the head comes out. If the baby never she's pushing for 4 hours and the baby just doesn't come out, that's an easy decision. That's a C-section. There's not much more to do. The scarier thing, which people don't realize, is like the baby's like kind of inching through, the labor's taking like forever, and pushing's taking for a long time, but no one wants to quit because she's like complete and completely dilated pushing, and then the baby's head comes out great, but the whole rest of the body is stuck. And like I said, there's only so many maneuvers we can do, and I don't even like talking about what some of those maneuvers are, and because it kind of will shock someone, but they're safe. But in that process of doing some of those maneuvers, the baby can have some injury in rare cases, brachial plexus injury, where you get some nerve damage along the arm. The baby can have, some degree of hypoxia sometimes in that process. And then if you still can't get the baby out, there's really not a lot of maneuvers. We can't do a C-section at that point. And there's not a lot else we could. There are, but they're so extreme. And like any of us that have had to do those extreme measures, I've lost many years of my life having to do some of those maneuvers, and we just don't like that. We don't like being put in that position. So I totally understand from the mom's standpoint, like, well, it just doesn't fit with what her idea, what the process was going to be. But, most, women they're only going to have 1 or 2 deliveries, maybe 3 that they experience. And so, but, I've done like 7,000. And so you just start seeing things, and I just don't know who it's going to be. And when bad things happen, it's very difficult at that point. I said you can't do C-section. There is this one rare maneuver, which I've never done, called the Zavanelli, where you push the baby all the way back up to try to do a C-section. But I think even Zavanelli just said you shouldn't be doing that particular maneuver, because it's just the outcomes are really bad at that point. So, and it's hard to talk about because I don't want to scare patients.
Right.
But I always say that one of the reasons why it's rare is because we induce everyone at 39 weeks that have a big baby, too.
Right.
So, yeah.
Okay. One really common question from our pregnant community around inductions is induced labor painful? And is it more or less painful than natural births, or even, just non-induced births?
Well, when you say natural birth, I'm not sure. I mean, if you mean spontaneous labor, but they're not using an epidural, let's say, the whole rest of the time, that's extremely painful. I think there's this... that's why I tell my patients there's this, and that's not to discourage women. I think if you're going to do that, that's more power to them, but they definitely should take Lamaze class. There should be some strategy. You can't just walk in to do it. But I think people have this idea that it's this really beautiful experience when you're going natural without an epidural, without, and just going the whole time. But it is not. It is sheer degree of pain that you can't imagine, and delirium. They're delirious. Like they're not aware of anything around them. They can't even enjoy anything about the birthing process. And even after the baby's born, they can't enjoy it that much because they're in so much pain. They don't remember anything afterwards. But that's not everybody, but that's been my experience from like 90% of the women. And some of it's cultural, like they're in some other countries, developing countries, it's like normal, and somehow I think from the time they're get pregnant, it's ingrained to them that you are a woman, you are strong, you can do it, and there's a community around them, and I think it's just a different mindset than I think your average, 39-year-old IVF pregnancy in Los Angeles,
Right.
But in terms of, is it more painful? Let's forget about going natural, just going to spontaneous labor versus regular labor. I don't know that it's more painful, but what I would say, it's more condensed. So if you're going into spontaneous labor, it's painful, but that pain might be drawn out over a week to get to 2 to 3 centimeters. So yes, it's uncomfortable. Yes, it's painful. Like the days, like when you're having it, it's uncomfortable. But it's kind of spread out, and then you get to 3 or 4 and maybe you're like, okay, I can't take it anymore. I gotta go to the hospital. And maybe you would get your epidural at that time.
Yeah.
Induction, you're admitted first. You're not contracting. Usually your cervix is closed or just a little bit open, especially if you're first time mom. So then we start the process from like ground zero. So I wouldn't say it's like painful initially, immediately, but as the labor progresses, it's painful, and it's condensed into a 24, 36-hour period as opposed to, let's say, a week, and then coming in and then delivering quickly. So, I mean, it's always more efficient, easier, better in the sense you're at home comfortable going to spontaneous labor and coming in. But by the time usually we're talking about inducing, there's something not normal about the pregnancy,
right.
unless they want it for logistic reasons or social reasons. But usually we're not recommending that, yeah.
Okay. How do you typically determine the right time for labor induction for a pregnant parent?
Well, if we're recommending induction, usually there's a reason, because we don't just recommend it for everybody. So it depends on what that reason is. If it's a medical reason, uncontrolled hypertension, then they might be 37 weeks, and we're like, we gotta induce you. Or they might have preeclampsia, and we don't let them go past 37 weeks. Or let's say they have twins, we don't let them go past 38 weeks if they haven't gone into labor, just because the stillbirth is higher after 38 weeks. But if it's not like a medical required indication that they have to deliver, let's say, soon, then let's say it's just the baby's kind of big, then we would say 39 weeks. And I don't think any hospital will let you induce before 39 weeks, just because even though it's still term after 37 weeks, there's a slightly higher risk of the baby having some breathing issues, needing to go to the NICU if you do it before 39 weeks. Yeah.
Okay. For the general average induction, what should a pregnant parent expect if they're getting induced?
Yeah, I mean, assuming they're not having any contractions at all and their cervix isn't very favorable, first of all, the induction gets scheduled. And I don't know if we mentioned the bio, but I work at Cedars-Sinai, so we do the most deliveries in California. So if you're at a really busy hospital, I think everyone's so used to immediate service for whatever needs they have in retail. So sometimes patients say, okay, I want the induction tomorrow, but it doesn't really work that way. It's such a busy hospital, so we have to schedule it well in advance. Usually we can't actually book it till about a week before, but so 7 days before, whatever date we want to book it right away. And then there's not a lot of preparation other than having your go bag ready, just your sort of overnight bag of the things you're going to need. And then I always say eat before you come in, because in most places, and certainly with us, once we get started, you can only have clear liquids. So that's something, sometimes women may not be aware of. And
is that for labor generally, or just if you're being induced?
If you're being induced. Now, labor too. So when someone comes in to get admitted for labor too, they can also only have clear liquids. So that would just mean like Jell-O, broth, water. And the reason for that is there's a slight smidgen risk of aspiration if we have to emergently do a C-section, and if we had to intubate you, which doesn't usually happen, we don't intubate people very often, then you can aspirate, and because that can be so severe in terms of the complications to your lungs, the anesthesiologists don't like that, and so that's why most places will institute clear liquids. So I always just say eat a pretty full meal before you come in, and then once you get started, there's just the usual process to get checked into the hospital, and then we might give misoprostol. It depends on, again, how your cervix is, what you're actually being induced for, who the physician is. But generally, we'd use misoprostol, which is a type of prostaglandin hormone that we might put in your mouth to dissolve, or in the vagina. We do that every 4 hours until your cervix, the woman's cervix, opens up a little bit. Then we can put a small balloon in. The balloon gets blown up. Maybe it's about the size of a walnut. And that combination, the Foley balloon, helps mechanically dilate a little bit, but it also separates the amniotic sac from the uterus, and that releases more prostaglandins, which helps sort of reform the cervix and soften and shape it. So we do that until the balloon falls out, which might be at 4 centimeters dilated, and the max is 10 centimeters before you can start pushing. Then we would start an IV drip of Pitocin medication, and that's the same peptide hormone that the brain produces to cause contraction. So it's the exact same thing, it's just that it's pharmacologically made, and we can titrate it. And then we just do that, and it's not a fast process, but if it's your first baby, it might be 24 to 36 hours before you deliver. Yeah.
Okay. Yeah. We've once gotten a comment on social media that getting induced involves softening your cervix with horse semen. Is that true? With horse semen?
Horse semen.
Yeah, like I think the cervical softeners that you mentioned are vaginally inserted. There's some conceptions that it's made of horse semen.
I've never heard of that. Yeah, these are made in like a very complex, sophisticated industrial pharmacologic factory. So they're not usually milking horses and stuff, for it. Yeah.
Okay, sounds good. Yeah. So another common question, I know you touched on this slightly in the last question, but another common question is, if you're getting an induction, how is your water broken?
Yeah, so when we rupture membranes, it's going to vary on the patient, and other things like if they happen to have group beta strep, we always swab for that in all patients, and if they have that or not, how the baby's looking. So it's not, I can't say it's like 100% applicable, straightforward, exactly what we would do it. I think in general, if everything's going fine, we might rupture them at 4 centimeters. It can vary, might be 3, might be 6, depends on the patient's preference too. And then we just have a small hook that we take in and we rupture it, and then that usually helps accelerate the labor too. So,
okay. Interesting. Mm-hmm. Another common question that might be slightly related is, what is sweeping the membrane and when is it used?
So we would usually do that in the office, and what happens is we'll check, the mom's cervix, usually for us at 38 weeks, earlier if they're having contractions. And you have to be dilated for us to be able to do a sweep. We insert our finger into the cervix, and we basically literally do a sweep. And I'm usually touching the baby's head, and I'm sweeping the membranes around the baby's head to separate it, just like the way the Foley bulb does that, where it kind of pushes the membranes away from the lower uterine segment. I'm doing the same thing, a little bit of cramping, and there's not a lot of data on it, I think, but from my experience, I usually say half the people will go into labor within 3 days. And so it's really funny, though, because patients will be like, oh, you got to deliver me. I can't, it's like too much pain, too much pressure. I'm like, okay, do you want me to sweep your membranes? And then and I tell them you might deliver next 3 days. And they're like, no, I'm not ready.
Along that line, what are natural ways that people can induce labor or even prepare for an induction?
Well, they've never found anything that can actually initiate labor. And it's very interesting. We still don't actually know what causes human parturition, the initiation of labor. I mean, there's some idea of some steroid release of this, but we don't really know in humans. So we know in primates, in sheep, and in all sorts of other animals, we don't know it in humans. And so they've never been able to figure that out, and they don't know what natural things, there's never found anything natural that can basically jumpstart labor. You'll hear a lot of things. So there are some things that can cause contractions. You're really dehydrated, you have diarrhea, you exercise a lot, you'll have some contractions for sure. Intercourse, because in semen there's some prostaglandins, but they've never shown that that would actually put people into labor or as a way to start induction. So mostly it's just a matter of, I think, of just being mindful and getting situated in a way where you're kind of ready for it. Because I find that is more of something that's causing anxiety for the patient, the unknown, more than the technical stuff of the induction. Yeah.
Okay, but sweeping the membrane can potentially
I find that it does.
Move it along.
Yeah, but there's not a lot of data. Yes, but I do
Right.
find that does. Yeah.
Okay.
Yeah.
Interesting. So you mentioned intercourse. A really common question when it comes to inductions is having sex a reliable way to stimulate labor? Are there any general guidelines that people should abide by if they are pretty far along?
It generally does not cause labor, and I could be wrong, but I've never seen any study that shows that it does. But I always say it doesn't hurt, so, if you want to give it a go, you can do it.
Okay, interesting. So I feel like in TV shows, for instance, and in media, it's a really common concept that people should have sex to stimulate labor. So is it just that it stimulates contractions?
It can cause contractions sometimes,
Okay.
yeah.
And that
But
inadvertently...
right, but so does, not drinking water or
Right.
being out in the heat,
Okay,
Yeah.
interesting. How many labor induction methods are there? Or is it really mostly like the Foley balloon and such that you mentioned?
That's most of it. There are other prostaglandins like Cervidil, which is like a prostaglandin that's it's like in a little flat. I don't
Right.
know.
That's used for IUD insertion too, right?
No.
Oh,
It's not used for
okay.
insertion. And then there's prostaglandin gel, which I don't know if it even exists anymore. And then there's technically laminaria, but no one uses that. So you'll read about it as a legacy, and that's like a small seaweed rod you put into the cervix, and it absorbs the fluid and expands mechanically. But
Okay.
I don't know of anyone that would use that.
Okay, so the main method of induction is with the Foley balloon and such that you mentioned, the
The
prostaglandins.
misoprostol and the Pitocin, yeah. It's kind of all roads lead to that, I think.
Okay.
So.
Are there any risks or potential complications that are associated with induction, especially if it's unnecessary?
Yeah, I wouldn't say it's the method, like it's not the induction itself, it's just labor, So what happens in labor is the uterus is contracting, of course, and when that happens, it cuts off all the blood flow to the placenta during that time period. So when that's happening, some babies, they don't have enough what we call reserve, the ability to handle that. It's like if you were to hold your breath and go underwater and then come back up. Well, you could probably do that a few times and not be fine. But if you're doing it for 24 hours, you might not be able to do that, and you don't have enough. Someone might not have enough reserve in their body, whether they don't have enough blood cells or particular types of hemoglobin in the blood to be able to handle it, and same thing with the baby. And so some babies, for whatever reason, can't handle it. We don't have the ability to peer that deeply in at a microscopic level into the fetus interaction during labor. And so usually it's not so much the Pitocin or the misoprostol, it's just that the baby can't handle labor. Now, if you give too much misoprostol, you give too much oxytocin, which is Pitocin, yes, because you have too many contractions. And then the baby's not being able to rest between the contractions. And so, but that just wouldn't happen because that's the whole point of being monitored in a hospital. That's what we'd monitor for. And the oxytocin is very short-lived, so we titrate it very tightly.
Okay. Okay, interesting. When is a C-section preferred over an induction or vice versa?
Yeah, that's another big question. I would say on how urgent the baby needs to be delivered. So if the baby's doing fine, you don't need to do a C-section. So usually when we're talking about C-section, it's because something's not going well with the mom or the baby. Most of the time it's the baby. And even if it is mom, something's not going well with mom, it'll eventually affect the baby. So if someone's like 3 centimeters and we think it might take another 20 hours for them to deliver, but we don't have 20 hours. The baby's not tolerating the labor, or mom's really infected and the baby's not tolerating labor, or the blood pressure of the mom can't be controlled with all the meds we're giving, or she might stroke out. Because the cure to a lot of the times with any type of high blood pressure related pregnancy conditions is delivery of the baby, then kind of cures the mom. And so it just has to do with that. Or quite often what happens is obstetrics is just so unpredictable, labor is so unpredictable. Everything can be fine for 99.9% of the time, and then all of a sudden, you know, in the last few minutes when baby's about to deliver, the baby just heart rate tanks, which usually means that there's hypoxia going on. Or at least there's a very strong interruption of oxygen to the baby, and we don't have time to wait another 20 minutes, 30 minutes, and we just have to deliver the baby. The only other time I can think of is if the baby's so big, like so if the baby's larger than 5,000 grams if they're not diabetic, or 4,500 grams if they are diabetic, it's better just to do a C-section than to induce. I'd say the other things that are better to do C-section when a vaginal delivery is contraindicated. So there's a lot of conditions where the placenta is like in the wrong place. It's like a previa, meaning it's blocking the canal. Breech presentation, the baby's facing the wrong way. Those things you just have to, you wouldn't even labor. You don't even try to labor. You just have to deliver by C-section. If they've had a prior myomectomy, where they've had fibroids removed, and usually you would just opt for doing a C-section.
Okay. So I know that that's kind of a question of like urgency. So is there ever, on the opposite end of it, a time when an induction should be rescheduled or delayed?
I don't know about rescheduled or delayed. I find that when it gets delayed, it's a logistic issue. So meaning, and I feel for the hospitals because it's an unpredictable thing. You don't know who's going to be coming in to the hospital in labor and what other emergencies are happening. So sometimes the labor floor is just too full. There's not enough nurses. And so the scheduled inductions coming in, they'll delay it. So that sometimes does happen. And I find it's usually associated with the time of the month. There's just certain months where it's just busier, and September's a busy month. Yeah. So I don't know if there are times where I would say it's planned, like, oh, yes, through medical judgment, it's better to delay it. Because once you know, there's a reason why you decided to schedule it when you scheduled it. So, yeah.
Okay, interesting. While we're talking about inductions, do you mind if I ask you a slightly more controversial question? Well, one interesting aspect that I've chatted about with midwives who have been on our podcast is just about how midwifery, it tends to be associated with lower rates of intervention and C-section and things like that. And I think a lot of people attribute it to OBGYNs leaning more surgical and being more risk averse. So yeah, I guess, do you have any thoughts around like the frequency of inductions and C-sections as it relates to OBGYNs, or their risk aversion, or general like rate of interventions and then complications?
Yeah, I think it's hard to, well, let me address the, first, I've worked with a lot of midwives, and I've been in teams where the midwives were essential parts of the teams and they did the delivery. I think one thing you find is that the midwives generally take low-risk patients. So that's one thing. So when you have a low-risk patient,
it will be associated with,
you're not going to much likely have a C-section. That's just a fact. And I think it really depends on the midwife. So just the same as the variability of the competence of the doctor, the midwife variability can be quite a big deal, and the licensing is quite variable. There's like certified nurse midwives, and it depends on the state you're in, and they're very different from a licensed midwife, different from a lay midwife. So it depends what you mean by midwife. If you're talking about like home laboring at home, laboring in the hospital, laboring in a birthing center. I've worked in teams where the midwives actually did high risk, and partly because we were just with them on the team. And so I don't know, I felt like we had the same C-section rate in a sense, because they had to hand it to us. They can't do the C-section because, but they were very skilled and capable. It also depends on the amount of experience, because some, I don't know, I don't want to misspeak, but I think for some of the licensing in some of the states, depending on the states, you don't actually have to have done a lot of deliveries to practice. So they don't, you just haven't seen the worst of things. And so I think when you've been exposed and seen more of the worst of things, even though it's rare, you might intervene a little bit more, because when those things happen, it is so painful, not only for the family, but for us providers. It's very painful, and we have to live with it for the rest of our lives.
Right.
And a lot of times when I speak to midwives, unless they're really, really experienced, then they know exactly, they're really good at judging, like, okay, we need to hand this over to the OBGYN. But if they haven't, it's like, I don't know, before 2008, when the real estate market never went down nationally ever, you just think that's impossible. It's impossible to happen. And so everyone has that same mindset when you haven't seen bad things happen. But let me tell you, once you've seen a handful of those things and you've had to deal with it, so I've had to deal with a lot of complications handed to me, because they get handed to me after things go really sour.
Right.
Because that's when I get, and I don't have a choice. I've got to take it a lot of times, especially because I've been academics a lot of my career, so we can't turn anyone down. So, there might have been a midwifery practice taking care of someone, and then things got really out of hand, and then they hand it off to us. And so we remember those things, and we remember. So I think it depends on the perspective you're coming from. And I always try to remind people the most dangerous time in a person's life used to be when they were giving birth and when they were being born, before modern obstetrics in the 1950s, And so before that, it was very common for women to die and babies to die.
Right.
Common, not like it was happening all the time, but it was really common compared to what it is now. So I think that it really just depends on which midwife you're referring to and stuff. But like, for instance, my C-section rate right now is 5%. And I'm not bragging about that, because it might be 30%, later, because it just kind of does this. But like for the last year, I think it's been 5%. And
it's interesting that you guys even track that individually.
Oh yeah. So it's tracked. Like no one will talk about it, but it's tracked, and we're reminded of it. But for me, I'll take a 30% C-section rate. The goal nationally is to be under 24% for first-time moms. This is very clear for like singleton, cephalic, meaning head facing down, correct, the correct way, it's not breech. First-time moms, that's what we talk about. It's called the NTSV rate.
Does ACOG track it?
It's not tracked in a way that it's on a national database, but what happens is insurance companies, Joint Commission, which serve as they kind of look at overall rates, and they say, where are you at? Yeah.
Okay.
And then the hospital in turn it depends on the hospital, but like at Cedars, the hospital in turn will then look at the physicians and say, hey, this is your rate. I mean, they're not going to tell you got to get it down, but there is this pressure.
Yeah.
Pressure's not the right word, but it's they're giving you this information for a reason, right? And I will still take a 30% C-section rate to be able to sleep at night. So, like I'm not going to risk the baby at mom just so I can push my rate down. You know? But the reason why I talk about my 5% rate is just simply because I think a year ago or 2 years ago, it might have been 27%. I haven't changed anything in my decision-making, but maybe the patients that happen to come or that happened to labor at that time, maybe it's changed for some reason, or it's just chance. And so it's important to look at as a policy. It's important to reflect on, I think, to see if there's something we can do to reduce the C-section rate. But at the same time, like I want to make sure I can sleep at night, that I did the right thing. The most interesting thing, there's only one thing that's been shown to reduce the C-section rate. Of all the things that have been tried, of all the things that people talk about, intervention, as far as I know, there's only one thing that has reduced the C-section. Now, truly across the board, there are some things that have shown reducing C-section rate a little bit, like, I don't know, like doing certain techniques in like the induction or this and that, but they're all kind of sporadic. Universally across the board, randomized controlled trial is induction at 39 weeks.
Oh, interesting.
So it used to be this thing up until maybe 2018 when the ARRIVE trial came out that induction wasn't bad, but it wasn't good. Like, oh, yes, you had to do it for medical reasons, let's do it. But we don't want to just do it because we're going to increase the risk of C-section. And that came from these observational trials, retrospective trials. I don't want to get too technical about it, but they were basically, they looked backwards a lot of times. They said, oh, look, the people that spontaneously delivered, they had a less C-section rate than someone who was induced. But they weren't randomized. It wasn't a randomized controlled trial. And then somewhere along the way, some smart investigators found out that's not the correct thing to look at because you can't choose, a woman can't choose spontaneous delivery. I mean, she's thinking she's choosing it when she doesn't get induced, but you can't choose it because you may not go into labor. So it's not fair to compare those two. So when the ARRIVE trial was developed, and this is like 41 institutions, like 6,000 women, I think, were involved. So a computer code was given to them somewhere between like 34 to 38 weeks. A computer code was given to them, and for no other reason, the computer said you're going to be in the induction group. You're going to be in the expectant management group, meaning we're just going to wait to see if you go into labor or not. They enrolled in the study and they did it, and then there was a 25% less C-section rate in the induction group at 39 weeks.
Oh, wow.
So that's...
Why do you think that is?
So they looked at that. I think one of the things they found was that women are older now compared to the 1950s. 1950s, the average, who knows, they were like 20 years old. BMI was like 25, and now everyone's older, have medical conditions, medical problems. So sometimes I'll have someone's 45-year-old's IVF pregnancy, and they're like, I want to go naturally. I don't want to be induced. We induce earlier when you're over 40 to reduce the stillbirth rate. But I'm like, nothing about your pregnancy is normal. This is not a normal. This is not, a normal pregnancy. But they found that it has to do with the fact that people are older, people have medical problems, and then what happened to a lot of people was because they let them wait all the way up to like 41 weeks, a lot of them got preeclampsia while they waited. And then when they got the preeclampsia, they said, okay, well, let's induce you. And then that window period of letting them labor was really short because it just got worse and worse and worse. And at 39 weeks, you just sort of abbreviated, like before you got to that point of where you got preeclampsia. That's what they think was happening. So I just try to reassure everyone if we do need to induce you at 39 weeks, we're not increasing the risk of C-section. We're actually decreasing the risk. And what no one talks about in the ARRIVE trial study is interesting too, is that it actually reduced the maternal, neonatal death and morbidity. So the actual harm to the baby was reduced by 20%. Now,
what about maternal mortality?
No, because maternal mortality is so rare still. It just you can't find it with 6,000.
Okay.
You have to be looking at like 10 to 20,000.
Okay.
100,000. And they found that it actually reduced it. But what was interesting is they'll say that there was no difference in actually the baby's outcomes in either group. The reason why is they said it wasn't statistically significant. So I don't want to get too technical, but it's very interesting. They used the p-value. That's the statistical significant value at which you say, okay, now this is statistically significant. This means something. So it showed a 20% reduction in actual fetal morbidity, death, but it was at 4.9%, which normally that would be statistically significant. For most studies, it is. Those particular authors, before they stop the study to intervene to look at the data, because that's what you usually have to do for these large studies. You have to stop at some point and look at the data. They used 4.6 or 4.65 as the cutoff. I forgot what it was, and it was 4.9. So meaning if it's above 4.6, then we say, no, it's by chance. But in all studies, the p-factor, the p-value would have been 5%. It would have been statistically significant. So they were being extra cautious by using 4.6 or whatever it was. But that's not most studies. Most studies, and I don't know why they used 4.6, so they had some very smart statisticians look at it. So they decided that was the most conservative, best thing to look. But most studies would use 5%, a p-value 0.05 or 5%. So I'm like, well, that's a big deal, that you were able to show that it actually improved like the morbidity and survival of the baby, I think.
Right.
But, yeah.
Interesting. Why do you think having an induction improves the likelihood of survival for the baby?
Probably the same reason, stroke, preeclampsia that mom has later, and complications from that was occurred that caused that required the C-section to be done.
Okay.
Yeah.
Wow, super interesting.
Yeah.
You can tell you're an academic.
Yeah, I know. Sometimes I don't know when to like.
No, I think it's interesting.
To downplay the data and
Yeah,
stuff. But
no, that's awesome. Okay, cool. Well, I'd love to move into a postpartum care section. So does postpartum care look different if you've had an induction?
no, it shouldn't. It should
Okay.
be the same. Everything should be same. Recovery should be same. The only thing I guess I would add is sometimes it's a little more exhausting and tiring, only because if someone comes in at 4 or 5 centimeters from home, their labor might be short. Maybe it's 8 hours, 12 hours. Someone who was induced might have been 24 to 36, and that's just tiring to not being able to eat,
Right.
being up all night. So I would say just in terms of fatigue, maybe it's different, but it doesn't change in terms of anything in terms of our postpartum care or
Okay.
recovery. Yeah.
Okay. Are there any special concerns about mental health when you've been induced?
Sometimes I think when I think about postpartum depression and all that, it's not very predictable. It is predictable in people who already have depression, who already have anxiety for sure.
Right.
But if you take those people out of it, I can't usually tell, like, someone who I think they're going to end up with postpartum depression or anxiety, their postpartum depression score is like 0. We have a survey we always do, and they're like doing fine. And some of it also depends on how much sleep they're getting, how fussy their baby is. There's how much help they have. There's a lot of other factors.
Right.
So I wouldn't say it's because they're being induced, but I think sometimes I can see people who are very attached to things being a certain way. So if you're really obsessed and attached with, I wanted to go natural. I didn't want to do an epidural. I didn't want to have to get Pitocin. And now they grudgingly accepted it because their blood pressure is super high. We're worried
Right.
about the baby. I do worry that when you're too stuck on something and you're making yourself feel bad or guilty, then I'm worried that might, along with the hormone changes, lack of sleep, that might result in something. But I wouldn't say that's because of the induction. That has to do with the person, the way the having the induction occurred to them. Same thing with the breastfeeding. Some women have difficulty breastfeeding and breast pumping, and of course I encourage it, but I don't wrong them for it. I don't want to make them feel really bad because they can't do it. And the ones that are really stuck on the idea that this was the most important thing and I'm hurting my baby that I'm not doing it, those I'm very worried that their mental health is going to be affected.
Right.
Yeah.
Okay.
Yeah.
Interesting. Well, my last question is if someone is considering an induction, what would be 3 tips that you have for them, especially if it's an unnecessary induction?
And unnecessary? You mean just like they're just electively wanting to be induced?
Yeah, I actually know quite a few people that have been induced. Like one of my friends, she's one of 5 kids, and every single one of them has been induced. Her mom just always wanted to be able to anticipate birth and didn't want spontaneous labor.
I definitely see that the case after you've already have a child, because that logistic difficulty of not knowing when you're going to labor and having to have someone take care of your other child is difficult. I think the tips I would give for anyone that's going for an induction, whether it's for medical reasons or not, is one, I'm getting a little too philosophical, just to have a clearing of your mind and be just mindful in a clearing and not put too much meaning to the induction process. It's just another tool for you to meet your baby. I think the second thing is eat a very hearty meal before you come in, because you may not be able to eat for a while. And let's see. The third thing is things don't always go exactly the way we envision it, and if you can kind of just roll with that, knowing that everything's being done to have the best outcome for mom and the baby. And in the end, all that matters is that you're holding your baby and the baby's safe and you're safe, and that's the most important thing. I think that's mostly it. Oh, and the other thing is I always think it's good to get induced at night. at like late at night, because then the misoprostol balloon kind of goes in. Hopefully you can sleep a little bit. When you wake up in the morning, we start the Pitocin.
Okay.
So maybe 4 tips. So you don't always get control of the time that you're going to get, but
Yeah.
I think my patients are always surprised when I'm scheduling it for 2 a.m. And I'm always like, that's the best. If we can get that, that's like the best time. And so
Interesting.
Yeah.
Okay, cool.
Yeah.
One last question I have is actually about a comment that we frequently get when it comes to cord blood banking. So we, often tell folks, like, don't throw away your umbilical cord and placenta. Instead, you can repurpose it and, in a sense, like, repurpose what would normally be considered biohazardous waste. But we get a lot of comments that are kind of like, oh, you know that OBGYNs sell placentas. Why would you say that they're thrown away? So as an OBGYN, are placentas sold? And if they are not, then what happens to placentas and umbilical cords after birth?
No, we don't sell placentas, and I don't even know who you would sell them to. Like, who would want to buy them? But no, we don't sell placentas. We don't sell anything at all. We don't sell, literally, we don't sell anything. Like, we don't sell prenatal vitamins. We don't sell anything. Like, we don't sell anything. So, and just as an aside, maybe I'll just add, people don't realize, because sometimes they're suspicious about doctors and how they're benefiting financially. We're not allowed to get paid to promote or sell anything or prescribe anything. It's illegal. Just I want to put out that, because people are always surprised. So what happens after the placenta is delivered, it goes usually in a bucket, and if it doesn't need to be sent to pathology, so we send to pathology if we want the pathologist to look at it, because we're just thinking it has something to do with the medical condition. Sometimes helpful to know. And usually it goes through the hospital biohazard system. They're all required. Joint Commission, state laws, there's this whole things of processing biological waste. So usually it goes into this waste system that's handled by some third party, or maybe the hospital does it, and then it goes to some incinerator system because it's a biological waste. Actually, you get into a lot of trouble if you don't follow like the letter of the law and the rules for handling biohazard waste. So it's a big deal. I think I read recently, I don't want to name the hospital, but they got into trouble because they found biohazard waste dumped somewhere, and so it wasn't disposed of properly. So they're very, very, very strict about it. The health department, the state laws, so it's very, very stringent. So much so that some hospitals for a long time could not give the placenta to the patient because it's considered a biohazard waste, so you weren't allowed to. I think since then, over the last few decades, they've kind of worked their ways around it if you sign a release and all that stuff. But you couldn't, when I was a resident and early in my career, you couldn't give the placenta to the patient.
Okay. So if someone is looking to do cord blood, cord tissue, and placenta banking, how should they go about telling their physician or provider that they do want to store it? Because I think some patients have concerns around, like, I don't know if they'll give it to me. They were insistent at my last birth that they have to throw it away and things like that.
Oh, I don't know. I've never encountered any doctor who would be against it if the patient wants it. I would just say, talk to your doctor about it and then let them know. And usually for me, I just try to put a sticky reminder on the chart because we don't want to miss that opportunity. And usually the patient is bringing it to the kit to the day of their labor. So the nurse knows about it. The nurse is aware of it. In the intake, I think there's even a question intake that the nurse says that, yes, they're going to collect their cord blood. So
Okay, awesome. So if any folks do want to get in touch with you as a physician or a resource in general, how can they do that?
You know what? I didn't think about that. Let's see. I'm trying to think. I guess I don't have a huge public access way of getting hold of me. I mean, they can find me.
Doctors often don't, I found.
If you Google Cedars-Sinai and my name, David Kim, OBGYN, I think you'll find me, and you could call my office if you had something. But I do have a TikTok account.
Cool.
It's Dr. David Kim, I believe. It's been a while since I've been so busy. I haven't had time to post, but so I was trying to always respond to messages on that. So
that's
it's
awesome.
Dr. David Kim. So on TikTok, I have a same thing on Instagram. I don't really message people back on the Instagram so much because I get a lot of weird, like, bots. So I don't know who's real or not.
Yeah.
So I feel like for some reason TikTok's more like, they're more genuine. They're like the real person on Instagram.
Yeah, the comments are better.
And Twitter, like, I don't know, like, they just seem like bots, so
Right.
that's why I don't usually respond. Yeah.
Okay,
That's
interesting.
helpful. Yeah.
Okay, awesome. Well, yeah, maybe you'll find some fans. When we posted clips of our podcast with Dr. Rad, we got a comment that was like, "I drive 2 hours to see Dr. Rad. I love him."
Oh, wow. Yeah, it's kind of crazy. I think I don't think it's because of me. I think it's just Cedars in general. But I have patients fly in from Las Vegas, from San Francisco.
Oh, wow.
Drive from San Diego, from Orange County, and I'm always like, "You have good docs over there," you know. But yeah.
Yeah. Okay, great. Well, I really appreciate you taking the time to be with us today. This is a really insightful conversation.
It's fun.
Yeah, and I'm glad that you talked about the Arrive trial. That was really interesting.
Yeah. It just came out 5 years ago. It wasn't that long ago.
Yeah. Okay, awesome. Well, thank you so much.
Thank you. Good.